Welcome to Bullet Point Nursing. My name is Dr. Goldstein, and in this lecture series, we're going to go through essentially everything you need to know for nursing pharmacology. So whether you're here getting ready for the NCLEX to help you through nursing school or getting ready for nurse practitioner school, I hope you find this series helpful. All the notes that we use in this series are evidence-based, and you could download all of them off of our website. So today we're going to be talking about gastrointestinal pharmacology, and there's a whole bunch of drugs we're going to cover. The first diseases we're going to talk about is GERD and PUD. So let's start with a little bit of a pathophysiology review. GERD, also known as gastroesophageal reflux disease, is where the lining of the esophagus is exposed to the acidity in the stomach. So let's back up a second. In our stomach, we have what's called a gastric acid. This is a really acidic fluid, and it's meant to kill off or neutralize many harmful pathogens that are in the foods that we eat. That's easy for us to understand because we know that when we put things in our body, they're supposed to be sterile unless they're going in through the GI tract. If they're going into our mouth, obviously the chocolate cake that we eat doesn't need to be sterile. And this is in part why. Because the stomach is hopefully designed to kill off anything that would hurt us from getting past the stomach into where it would actually be absorbed into the body and where it could potentially hurt us. So this gastric acid is really acidic. And the stomach has a special lining to protect the stomach itself from getting damaged or hurt by this gastric acid. However, the esophagus does not have that protection. So if this acid from the stomach comes up into the esophagus, it can cause pain, damage, and other problems. The next thing we're going to talk about is peptic ulcer disease. Peptic ulcer disease is where the stomach, which has that protective lining we just talked about, where that lining actually develops a hole or an ulceration in that lining. Now that there's a hole there, the underlying tissue is exposed to that gastric acid. And again, that causes pain and other problems. The three primary causes of this are NSAID use or overuse of NSAIDs, such as ibuprofen or indomethacin, stress, as in the quote that you may be familiar with, don't get yourself worked up, you're going to give yourself an ulcer. This is what they're talking about. And finally, H. pylori, Helicobacter pylori, that's a gram-negative bacteria, and that's another one of the common causes of peptic ulcer disease. Next, we're going to talk about some non-pharmacological interventions. So the non-pharm interventions for both peptic ulcer and GERD include reducing smoking, reducing alcohol use, reducing your weight, avoiding spicy foods, don't lay down after eating, which also means don't go to bed right after eating, and finally, avoid or reduce your NSAID use because that can make it worse. These non-pharmacological interventions are meant to help your symptoms be managed, and it's meant to help you prevent your condition from getting worse to allow the body to heal itself. Now let's talk about the actual pharmacological interventions. The first drug class we have are PPIs, or proton pump inhibitors. These are very, very commonly used medications. They're available both over the counter and by prescription. The drugs we're talking about are omeprazole, pantoprazole. You're probably familiar with the brand names Prilosec, Protonix, etc. The mechanism of action here is that they inhibit the enzyme, the proton pumps, that generate this gastric acid. So what's their end goal? So we understand they inhibit the enzyme that generates gastric acid, thereby reducing the gastric acid. The point here is that we're trying to reduce the overall acidity of the stomach, because the more acidic and the more volume of acidic content the stomach has, the worse off this condition is going to be. By reducing that, by reducing the acidity, we're able to help the body heal itself. What do we use this for? We use it for GERD and also for peptic ulcer disease. Now, one thing that's important for you, especially if you're going through nursing school, because this is very common on a test, is to understand this is not meant to be taken long-term. Because if a patient takes this for more than, depending on what textbook you look at, roughly 2 to 3 months, more than 8 to 12 weeks, the body can become dependent on it. So let's back up a second. First of all, the directions, you should use this for 4 to 8 weeks, 8 to 12 weeks, depending what your textbook says, but you should not use it more than 12 weeks for sure. And the reason, like I said, is because the body gets used to it. And think about it. If I take this for a year straight and my body got used to that lower level of acidity in the stomach because I'm always taking this medicine, if I suddenly stop taking it and the acid level in my stomach suddenly goes back up to where it's supposed to be, but it hasn't seen that high level of acid in over a year in this case. The body's not ready to deal with that, and it can cause problems. It can cause pain and discomfort. So if a patient is prescribed this, they should be educated not to take it long term. However, you likely know many people that are taking this long term that have been taking this for years. At the end of the day, that does happen. A lot of patients are taking this long term. We have to just monitor it. At this point, a lot of times it is very difficult to get them off of it, and we don't necessarily push for that in those cases. Again, that's a little bit beyond the RN level, but I know you're going to know people that are on this long term. I don't want you to freak out and tell them, oh my God, you got to stop taking it. Once they've been on it long term, very often we have to just keep them on that. PPIs, along with H2RAs, which we're going to talk about next, are the two most commonly used medications, daily medications, for the treatment of GERD or peptic ulcer. Between these two, it is good to know that the PPIs are more potent, they're more powerful. So keep that in mind. Doesn't necessarily mean it's better. And in some patients, we may actually prefer the weaker version because if that works, why go with the stronger one? But good thing to know. As far as adverse effects, there's one big one that you would be expected to know, especially for test taking, is that it can increase your risk of fractures. And this is more so in high-risk populations. What am I talking about? Postmenopausal women. And in those cases, especially if they're taking it long-term, we definitely encourage them to supplement with calcium and vitamin D. You will also sometimes see this used in hospitals, especially ICUs, taken every day, and it's for the prevention of ulcers in hospitalized patients. If you remember from a few minutes ago, we said one of the top 3 causes of peptic ulcer disease is stress. Stress doesn't have to mean stress from work or boyfriends or nursing school. Stress could be stress on the body because you're sick or you got involved in an accident. That's all actual stress on the body. That's trauma to the body, and that can cause ulcers. That's the logic. It's controversial, but that's why some hospitals give it, even if the patient doesn't have GERD or peptic ulcer, they give it to prevent it, just so that you know that. The next drug class we have are the H2RAs, histamine 2 receptor antagonists. You'll remember we had histamine 1 receptor antagonist. That's what Benadryl is. But in this case, we're talking about H2RAs. And again, you're probably familiar with these drugs. They're available over the counter. Famotidine, ranitidine, those are Pepcid, Zantac, and there's several others. What do these drugs do? Well, they get the exact same end result as PPIs, just not as strong of a result, but they work a little bit differently, but they have the same net result. They reduce the gastric acid and the acidity of it. What are these used for? Again, GERD, peptic ulcer disease. However, for peptic ulcer disease, we are more likely to go with PPIs because we want that ulcer to be able to get healed and move on versus H2RAs are not as potent. So in the case of peptic ulcer, we would usually prefer PPI. That doesn't mean an H2RA is inappropriate for a patient with peptic ulcer disease. This medication, unlike a PPI, works both daily and as needed PRN. PPIs should only be taken daily. That's not a PRN medication. This medication, because it does the same thing, it lowers the gastric acid. We don't want to be taking it for more than 2 to 3 months, again, depending on your textbook. Why? Because if the body gets used to that lower acidity level, it's going to be very difficult for the body to adjust to going back up to that acidity level. If a patient is on this medication and they're not getting relief from their GERD or peptic ulcer disease, we do recommend switching to a PPI. The next drug class we have is a pepsin inhibitor. There's only one drug here that we're going to talk about, and that's sucralfate. This medication is also used for peptic ulcer disease and GERD. However, peptic ulcer disease. However, this one works differently. This medication works by creating a coating or a protective lining over the ulcer. So remember, let's go back to the pathophys. In peptic ulcer disease, the stomach developed a hole in that protective lining, and now these juices are exposed to the underlying tissue, and that's really painful. This medication coats the hole so that those gastric juices can't get down and damage the tissue so that the tissue can heal itself. What do we use this for? We use it for a duodenal ulcer. Again, this medication is also not meant to be used long-term because that's not a long-term solution for peptic ulcer disease. The big downside to this drug is it needs to be taken 4 times a day. Remember, the more times per day a patient has to take the medication, the lower the compliance. The last drug that we're going to talk about, actually the second to last drug we're going to talk about in terms of for peptic ulcer disease, is misoprostol. Misoprostol, you may recognize this medication because especially it's been in the news lately a lot. Right now we're April 2023. It's all over the news because this is one of the two drugs in the combo abortion pill in the United States. When patients get the abortion pill in the United States, it's going to be misoprostol and mifepristone, those two together. So this is one of those two. What is it? It's a synthetic prostaglandin that replaces those prostaglandins that are consumed by NSAIDs. If you remember back to the video that we did, the lecture on NSAIDs, we talked about NSAIDs are COX-1 and 2 inhibitors. And that's, again, related to the production of prostaglandins, which cause painful inflammation. So by this being a synthetic prostaglandin, it can replace some of what NSAIDs block. What does all of that mean? That means that this medication undoes the harmful GI effects of NSAIDs. So it helps prevent a patient from developing an ulcer related to NSAID use, only related to NSAID use. This doesn't prevent a patient from getting an ulcer from any other cause. This just prevents a patient from getting an ulcer if they would get an ulcer because of chronic or long-term NSAID use. Adverse effects, this can cause some GI symptoms. Many of you may know this from the abortion pill. Also, please note, this medication is absolutely teratogenic, nothing to talk about. It will cause an abortion in a patient that is pregnant. You do not give this to a patient that's pregnant. Generally, most guidelines say do not even give this to a female of childbearing age. Finally, another thing that we have for treatment of GERD or peptic ulcer disease, this helps the symptoms. So I want to be really clear because that's fair game for the test. What do we take for symptom relief of GERD or peptic ulcer disease? And antacids could be a correct answer there. The other ones, maybe not. This one would be. What are we talking about? Aluminum hydroxide, calcium carbonate, that's Tums, and there's many other over-the-counter options. What does this do? This directly and very, very quickly lowers the pH in the stomach, lowers the acidity level in the stomach. I'm sorry, increases pH, lowers the acidity level. Remember, those are inversely related. So by lowering the acidity in the stomach, it is going to quickly make that gastric acid not as painful to the ulcer or to the GERD, the esophagus. So what do we use it for? We use it to manage the symptoms. It's not going to fix the underlying problem, but it will make the patient feel better. Do know the onset, because that's fair game for a test. This one, what would be the optimal medication for a patient who wants rapid relief of their symptoms of GERD, indigestion, peptic ulcer, however the question's phrased. And over there, the correct answer would be antacids. These work. Most of them advertise that they work within 5 or 10 minutes or so. So that's a quick, rapid relief. One big thing to know about antacids, actually one of the big things to know, this cannot be taken with any other medication. We discussed in one of the first lectures, if not the very first, the fact that a lot of medications can't be taken together. And what we mean by that is, let's say a patient shouldn't be on this beta blocker and this calcium channel blocker at the same time because they both do the same thing. So that's two drugs that just shouldn't be taken. A patient shouldn't be on both of them, period. In this case, we're not saying that you can't be on other medications. We're saying that before or after, usually 1 hour before or 2 hours after, some textbooks may be a little stricter, 2 hours before, 4 hours after. But in any event, in a certain time frame period beforehand and after, you should not take any other medications, period. When we take antacids, let me explain the reason behind this. When we develop medications, not we, I don't develop medications, but when we develop medications, we develop them specifically to go through the human body, to go through the trip in the esophagus, to go through the stomach, to go through the gastric acid, to make it into the GI tract, to get absorbed, go through the metabolism, et cetera, et cetera. They're specifically formulated for the way the stomach normally is, for that acidic environment. If we suddenly rapidly change that acidic environment and expect my medication to work the same, we may be in for a surprise. For that reason, 1 hour before, 2 hours after taking an antacid, we do not take any of our regular medications. If we're supposed to take the medication at the same time, we delay it or take it earlier. Depending on which specific one we're talking about, whether it's Tums, whether it's Rolaids, whatever it is, we do want to advise the patient that they may develop some GI effects, specifically diarrhea or constipation. If a patient overdoses on antacids, that is one of the most common causes of metabolic alkalosis, which in general is relatively rare, but metabolic alkalosis, one of the most common causes is taking too many antacids. Finally, If the patient had peptic ulcer disease related to H. pylori, because remember we said it could be NSAIDs, it could be ulcer, it could be other things, but if it's related to H. pylori, not only are they going to need a PPI, they're also going to need some antibiotics, and you wouldn't need to know this unless you're at the NP level. Usually we also give them not only PPI, not only antibiotics, we also usually put them on bismuth subsalicylate, depending on what guideline you're looking at. So let's move on from peptic ulcer disease and GERD, and let's talk about the next pathophysiology, which is going to be constipation. Let's do a quick review on GI processing so we understand what we're talking about. Peristalsis is rhythmic contractions, and it's how things move through the GI system. So I squeeze, 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 and that's how I move it, similar to how you would move toothpaste or how you would eat a freeze pop. Keep in mind that this system is not only used by the GI tract, some of our blood vessels, especially when they're really distal capillaries, they don't have that pressure from the heart to keep the blood moving. They also use peristalsis. Moving on, so let's talk about why that's important. As what's moving through our GI system, depending on the peristalsis, whether it's fast or slow, how much we absorb of that. So for example, someone eats a meal, banana, yogurt, juice, and it goes into their GI system. As it's moving along, the body's pulling out some calcium, pulling out some hydrogen, pulling out some H2O, pulling out some whatever else, some amino acids, some proteins, whatever the body needs to absorb nutrients from your diet. As it's moving along, the body's absorbing more and more until it gets to the end and it goes out. Throughout this process, the body's constantly pulling more and more out of it. If it moves really slow, the body is going to pick it clean. If it moves really fast, then a lot of it just comes out. It doesn't actually get absorbed. So what is this? What's the consequence of this? Really simple. If we have really fast peristalsis, the body doesn't pull a lot of water out of what we consumed into our GI system. So if someone had a full glass of juice along with their yogurt and banana for breakfast, that full meal of juice and everything is going to end up in the GI system. It's going to end up in the small and large intestine, and the body's going to start to absorb all of that juice. However, if it's moving through really quickly, the body doesn't get a chance to absorb that water. It keeps going, and it makes the feces into diarrhea. It makes them watery. On the flip side, if it goes through really slow through the GI tract and the body's just pulling and pulling out of it, it pulls every last drop of water out of it. All that's left is a solid brick, and that becomes constipation. So the next two things we're going to talk about are diarrhea and constipation, and now hopefully you understand the pathophysiology. So first we're going to start talking about what we use to treat constipation. And I want to begin with the non-pharmacological interventions, because that's where we always begin. Non-pharmacological interventions for the treatment of constipation are three things: increase activity, increase fluid, and increase fiber. Those are the three non-pharmacological interventions you want to teach your patient, okay? On the flip side of that, it should be obvious that those are also the three risk factors for developing constipation: immobility, not enough fiber, and not enough fluids. So let's move on to the first class that we have to address constipation. And this is generally our first line option. They're called bulk forming laxatives, and basically they're fiber. So psyllium is one of them, methylcellulose is one of them. These are both over the counter. You may recognize the names as Metamucil, Citracil, and others. What are these used for? They're used for treatment of constipation, and they're used for preventing constipation. Preventing constipation becomes a very large issue in a lot of patients. Most of us think of that in geriatric, and it certainly is, but a lot of patients have that issue. And this is something that is very safe to take every single day to prevent that from happening in the first place. This medication, do know that it takes 1 to several days to kick in. So if someone already has constipation and they're using fiber to get rid of that constipation, it's not going to be a quick process. It's going to take a few days for that to work. This medication, like we already said, is first line, and it is safe for long term. The next option we have, and these are not in any specific order, so don't think this is second line or third line. The next one we have are surfactant laxatives. This is a stool softener, and this helps water enter the stool. We already said if all the water gets pulled out, that's what turns it into a brick. So if we let water enter the stool, that will help it move it along. What do we give this for? Again, treatment and prevention of constipation. Again, this one takes more than a day to work, so don't tell the patient, here, take this, and within 6 hours you should have a bowel movement. Doesn't work that way. It takes 1 or more days till it works. I do want to go back 1 second because I didn't really get into the mechanism of action here. We said that this is fiber and that it's a bulk forming laxative. What does that mean? It basically bulks up the stool. And what the effect of that has, of bulking up the stool, it allows water to come back in. It allows water to be reabsorbed into the stool, and that helps the stool move along. Like we said, when it becomes a dried up brick, that's when we end up with constipation. So both of these first two essentially do the same thing. They both help water enter the stool. They just do it in 2 slightly different ways. The next drug class we have are stimulant laxatives. And the drugs here would be bisacodyl, which is Dulcolax, Senna, and there are others. The mechanism of action is this stimulates peristalsis. So this says, hey, let's keep it moving. Let's keep it going. We don't want to just get all the water pulled out of the stool. We want it to move on along at a better speed so that we're not pulling too much water out, that we retain water, and we're able to keep it moving all the way out. What do we use this for? We use this for when it's constipation, but when it's related to slow peristalsis, such as opioids. Opioids are famously, or infamous would be the proper term, infamous for causing constipation. How does it cause constipation? Because it slows down peristalsis. Well, we can give this to speed up peristalsis. This medication does have a risk of dependency, so please note that. Have that in your mind, first of all, for test purposes, second of all, if you're putting a patient on it. And the fourth class of drugs we're going to talk about for the treatment of constipation are osmotic laxatives. Drugs in this class are magnesium hydroxide, polyethylene glycol, lactulose, and these work by retaining water in the stool, increasing their softness, and promoting peristalsis. So this has a 2-pronged approach to treating constipation. This one, as well as the one before it, I didn't highlight that, but bisacodyl, this one is expected to work within just a few hours. Same thing with this one, the osmotic laxatives. Also, their onset is within a few hours. I would know that. That's definitely fair game for the test, because a patient probably does want to know, A, when they're going to get relief, and B, when they're going to have to spend a bunch of time in the bathroom. Polyethylene glycol PEG solution is also used as an evacuant to empty out the bowels as a bowel prep prior to procedures. A few quick points about constipation, and then we're going to move on. Mineral oil can be used. It's taken PO for constipation, and it can be inserted rectally for fecal impaction. Laxative may be abused for weight loss. Not only that, it may be abused by people that think or actually do need it to have continuous bowel movements, and they say that as soon as I stop taking it, I develop constipation. Well, that may happen, and they may then become dependent on these medications long-term if they use them regularly. So warn your patients about that. And finally, we already covered non-pharmacological interventions. Now let's switch. So far we talked about constipation. Let's move on and let's talk about diarrhea. So for the treatment of diarrhea, and again, I want you to think about these 2 diseases, not diseases, but symptoms, diarrhea and constipation. I want you to think about them on a spectrum. On one side is constipation, on the other side is diarrhea, and we want to be in the middle. But anytime we're on one side, our treatment is meant to move us to the other. So if we were constipated, we want to become a little bit more like diarrhea. If we have diarrhea, we want to become a little bit constipated. So we just finished talking about how opioids slow down peristalsis and cause constipation. Well, if I'm over here with diarrhea, if I give you a medication that's going to pull you towards constipation, that helps. So opioids work by slowing down peristalsis, which is a known side effect of giving opioids. But in this case, we want that because we're using it to treat diarrhea. So the 2 drugs we're going to talk about here are diphenoxylate with atropine and loperamide. Both of these drugs are opioids, and both of them work by slowing down peristalsis. By slowing down peristalsis, we're going to allow more water to be absorbed out of the feces so that they're not watery coming out. I do want to point out right here where it says diphenoxylate with atropine, these drugs are opioids. Now, one of these, loperamide, is actually available over the counter. It's Imodium, and it works by slowing down peristalsis. This medication is still technically an opioid, but it only works on opioid receptors in the GI tract. Diphenoxylate also works on the GI opioid receptors. However, if taken in excess, it can get a patient to get the effects of an opioid. It can get them a high. For that reason, to prevent abuse, we always mix this medication, or I think it's always, diphenoxylate with atropine. And what that does, if someone tries taking a whole bunch of this to get that high, because they're taking a whole bunch of diphenoxylate and because it's mixed with atropine, they're also taking a whole bunch of atropine. And the atropine part of it is going to make them really, really sick. So for that reason, we mix the two to prevent abuse. Next, what are the adverse effects? There are some adverse effects. Neuro and GI symptoms are most common, as well as pancreatitis. Diphenoxylate is a controlled substance. It's the lowest schedule. It's a Schedule 5, but it is a controlled substance. The other one we already said is available over the counter. Next, we have bismuth subsalicylate, very famously known as the pink drink or Pepto-Bismol. The mechanism of action here is it takes direct action against viral and bacterial GI pathogens. So what it does is if there's something in our GI tract that's causing us to have diarrhea, this will inactivate it. Hopefully, it'll bind to it and hopefully inactivate it so that that effect of that pathogen, the diarrhea, ceases. What do we use this for? We use it for treatment and prevention of diarrhea, and we use it for dyspepsia. Dyspepsia is a constellation of symptoms, nausea, indigestion, etc. This medication is also available over the counter. It's relatively safe to use, very, very popular, and has minimal side effects. The next thing we're going to talk about is dicyclomine. Dicyclomine bentyl is an anticholinergic, and that's used for IBS. That's not really extensively taught. We covered it a little bit in the anticholinergic lecture because it is an anticholinergic drug, but I just wanted to give it a quick mention here because it is used for irritable bowel syndrome, which is kind of a little bit what we're talking about right now. Depending on what type of IBS a patient has, it could cause constipation or could cause diarrhea. At some point, I wanted to cover it in this lecture. Finally, if a patient has diarrhea, make sure you're assessing them for fluid and electrolyte imbalances. And if they do have that, obviously make sure you're treating it. So what would be an appropriate assessment on a patient taking an antacid or a medication for constipation or a medication for diarrhea? Fluid and electrolyte imbalances would be correct, or take it a step further, a CMP would be correct, or urine Oz would be correct, things like that. Skin turgor, all good choices. Next, let's move on to nausea and vomiting. Nausea can be related to a whole bunch of conditions, such as bowel obstruction. It could be pregnancy. It could be someone having a heart attack. It could be that someone took in something that the body's not happy with, such as alcohol. All of these can cause nausea and or vomiting. Just like I said with diarrhea, any patient who comes in with vomiting, not just nausea, because nausea wouldn't make you fluid and electrolyte imbalance, but vomiting would. So anyone who comes in with vomiting, especially if they're children, if they're pregnant, or if they're elderly, make sure you assess them for fluid and electrolyte imbalance. I'm sure most of you know that pregnancy can cause problems with nausea and vomiting, which can result in fluid and electrolyte imbalances. That's known as hyperemesis gravidarum. So in these patients, we also want to figure out, not only rule out what is causing it, so make sure they're not having a heart attack, check for that bowel obstruction. If they're pregnant, then treat them accordingly. But we also want to make sure that's not any of their medications. As you may have already seen throughout your pharmacology training, tons of medications cause nausea, so many that I don't even list it in these lectures because basically everything can cause nausea or a headache or all those common vague symptoms. But because of that, here it's really important as we're talking about nausea, look over the patient's medication list, ask them what supplements they're taking, what CAMs they're taking, to make sure that whatever they're taking is not what's causing their nausea and vomiting. And if it is, make sure to address it. So our first line agent that we have for nausea, most of you are probably familiar with the medication called Zofran. We're not going to call it that. We're going to use the proper name, which is ondansetron. The mechanism of action is that it blocks 5-HT3 receptors in the CTZ, chemoreceptor trigger zone. The CTZ, you're going to see this as part of the mechanism of action of almost all of the nausea medications, because the CTZ, the chemoreceptor trigger zone, is part of what's responsible for stimulating us to become nauseous and stimulating actual vomiting. The indications for this medication, it's used for nausea, it's not used for anything else. It is the first line agent. It does have two adverse effects. One is a headache, one is QT prolongation. The headache is relatively common, so I do think that's good to include here. It's fair game for a test. This does come in several different forms. It comes PO, it comes IV, IM, and ODT. ODT is an oral disintegrating tablet. Hopefully you already learned this in your lab or skills portion of your nursing training. But what it is, you have the patient place it onto their tongue, it dissolves into their saliva, and they swallow it that way. One thing I want to point out, if a patient comes in for nausea, this medication, PO or ODT, is perfectly acceptable. If they come in with nausea and vomiting, not the best idea. If they come in with nausea and vomiting, if we have IV access, or if we have the ability to give an IM injection, if we're outside of the primary care office, or even if one that does have that, then it would generally be preferable to give it IV or IM, because if you give it PO and the patient spit it up before it got absorbed and metabolized and kicked in, then what good did you really do? This can also get into the really complicated subject of what do we do if a patient vomits up a medication? First of all, document it. Second of all, if a patient vomits up after you give them medication and you can still see the full pill in the vomit, you chart that the medication immediately came up, and now the patient is good to get another dose. However, don't just right away give the dose. Check with the provider. They may want to switch the route to IV or IM or something like that, but definitely make sure and document that. If it had been more than 30 minutes, then generally speaking, that's considered that the patient got the medication. If it's somewhere in between, check with your charge nurse, check with the provider. Next drug class we have, and these are generally second line, but I'm not going to put anything to it. I'm going to call all of them alternatives to the first line, the ondansetron. This drug class is phenothiazines. If you're watching these lectures in order, you've already seen the mental health lecture, and we had a group of antipsychotics, the medications for schizophrenia, and those were also referred to as phenothiazines and non-phenothiazines. The reason I bring that up is because those medications, if you watch that lecture, are very famous for causing EPS, extrapyramidal symptoms. Well, guess what? Because this medication is almost the same class, same formulary and structure, this medication can also cause the same issue of EPS. So what drugs are we talking about? Prochlorperazine, promethazine, that's compazine, Phenergan. I think Phenergan is probably much more used today than compazine is. How does this work? This works by blocking dopamine in the CTZ, chemoreceptor trigger zone. At the RN level, that's probably a bit much to know for pathophys of how this works. At the NP level, that's definitely fair game to understand the chemoreceptor trigger zone is part of the mechanism responsible for triggering nausea and or vomiting. Adverse effects, we just said EPS, extrapyramidal symptoms, also anticholinergic effects, also hypotension and sedation can be resulted. This drug does have several black box warnings that it can cause EPS, that it can cause severe tissue dermatological issues, and that it should not be used in children under the age of 2. Metoclopramide, I left it outside of the drug class, depending on what textbook you're using. Some consider metoclopramide, Reglan, to be a phenothiazine-like drug. Some have it in its own class, some have it differently. So I just left it on its own. The mechanism of action here, again, is the exact same as the phenothiazines because, like I said, some texts even consider this to be in the same class or very similar. The indications for this are gastroparesis, GERD, and chemotherapy-induced nausea. We do also use this a lot as an alternative drug to ondansetron for patients that have nausea, especially for nausea that's refractory. If you don't remember what that is, go back to the first video. Refractory to ondansetron. Off-label use of this medication is also for migraines, tension headaches, and in addition to nausea as well. Now, I do want to point out one thing. Remember, when we're talking about nausea, and I also mentioned this in diarrhea, it is fair game to say what would be an appropriate intervention for a patient, and assess for fluid or electrolyte imbalance would certainly be a correct answer, but take it even a step further. Would it be, which of the following might you need in a patient that is being prescribed metoclopramide? And fluids, it could go straight to normal saline in a test question, because yes, if a patient is vomiting, generally speaking, they may become fluid deficit. That's certainly realistic, certainly within the realm of what can be tested on, that you should expect if the patient's vomiting, that you're going to have to give the patient fluids, especially if we're in the ER setting. That's really common that we give patients fluid if they come in with vomiting. The next drug class we have are anticholinergics, and we talked about this in the cholinergic pharmacology lecture. The one drug we have here is scopolamine. This medication, I believe it's by prescription only. It's an anticholinergic, and I'm not going to get more into that. We covered it in the cholinergic lecture, but it's used for motion sickness-related nausea. Adverse effects, well, any of the anticholinergic effects, as we spoke about in the cholinergic lecture, such as a dry mouth. Next, we have histamine 1 receptor antagonist, also known as antihistamines. Remember, in this lecture, we also had the histamine 2 receptor antagonist, the H2RAs. Here we have the H1RAs. Nobody calls it that, but histamine 1 receptor antagonist. The drugs that we have specifically here, now we're talking about using this not for allergies like we did in another lecture. Now we're talking about it for nausea. So the two drugs we would use for nausea are doxylamine and hydroxyzine. Doxylamine is really only used for pregnancy-related nausea, for hyperemesis gravidarum. It is available over the counter, and it is often used for that. The mechanism of action for this, it blocks histamine 1 receptor antagonist. We know that. It also decreases histamine, which causes sedation. We know that too. These are a first-gen antihistamine, which means they do cause that fatigue and that drowsiness. What do we use this class for? We use it for insomnia. We use it for anxiety. We use it for allergies. And we talk about it in each of those. We talked about it in mental health for anxiety and insomnia. We talked about it in pulmonology for allergies. Today, we're talking about it for nausea because we do use this for nausea. And again, doxylamine is available over the counter. Pyridoxine, or B6, is a vitamin, and that is often in the guidelines for nausea relief in pregnancy, along with doxylamine. Finally, when a patient takes chemotherapeutic agents, that's anti-cancer medications, they can get some of the worst imaginable nausea as a side effect of those drugs. Because of that, we have extra medications that we give to those patients. So for those patients only, for chemotherapy-related nausea, we may give them cannabinoids, steroids, or benzos to relieve their nausea. All of those are overkill by far for nausea. However, for the treatment of chemo-related nausea, those are approved medications. Finally, again, because of how bad chemo-related nausea can be, those patients do get their medication very often before they even get their chemo, before they're nauseous, to prevent it in the first place. That's pretty rare. We don't generally treat a condition before it develops. In that case, we do. Thank you so much for watching. Have a great day.